Hello, everyone. Welcome to the anesthesia clinics. Today, we're going to talk about the intravenous induction agents, part 3. Today, we are going to discuss more about thiopentone and the other barbiturates, which are fall in the similar group. Thiopentone has been used for many, many years. It was one of the most popular choices of an IV induction agent till few years back. But with the advent of propofol, it is sort of falling back and not so popular anymore. The first choice everywhere is propofol now. But still, it is important to know there are certain indications where it is used, and many centers where propofol cannot be used due to the cost issues. It is still a popular choice. Okay, in a structure, it is derived from a barbituric acid. It comes in two forms: thiobarbiturates and oxybarbiturates. The thiobarbiturates are thiopentol and thioamyl. Oxybarbiturate is methohexital. Replacing the oxygen at the C2 with a sulfur atom, it increases its lipid solubility. Thiopental and thiamyl have a greater potency, more rapid onset of action, and shorter duration of action after a simple sleep dose compared to pentobarbital. Standard solution 2.5 has a pH of more than 9. So as you can see, this is a very alkaline pH. Mechanism of action. It depresses the reticular activating system in the brainstem, which controls consciousness, binds to a GABA A receptor, potentiates the action of GABA in increasing the duration of openings of a chloride-specific ion channel. The pharmacokinetics, absorption. Prior to the introduction of propofol, they were frequently administered intravenously for induction of general anesthesia in adults and children. Rectal methohexital was used before for the induction in children. So in the doses, if you're using thiopental, 3 to 4 milligram per kilogram, onset of action 10 to 30 seconds. Okay, intravenous maintenance infusion 50 to 100 milligram every 10 to 12 minutes if you're doing under total intravenous anesthesia. For methohexital, you can use an induction dose of 1 to 1.5 milligram per kilogram, and the onset will be again 10 to 30 seconds. For the maintenance, you could use 20 to 40 milligram every 4 to 7 minutes. Distribution, the duration of induction is determined by the redistribution. Okay, it's highly lipid soluble and highly non-ionized fraction accounts for the rapid brain uptake within 30 seconds. But for some reason, if you are, patient is hypovolemic, or the albumin is low because again it is highly protein bound, or the non-ionized fraction is greater due to persistent acidosis, or then you will get a sudden high toxic doses, that is high brain and heart concentrations will be achieved. Loss of consciousness within 30 seconds, and patient will be awake after 20 minutes. Rapid initial distribution half-life of few minutes, and elimination half-life ranges from 10 to 12 hours. Biotransformation, it is metabolized by hepatic oxidation to inactive water-soluble metabolites. Methohexital is cleared more rapidly compared to thiopental, and full recovery of psychomotor function is, of course, more rapid following methohexital. Excretion, except phenobarbital, it is limited to water-soluble end products of hepatic biotransformation, and methohexital is excreted in the feces. The CNS effects, dose-dependent depression of central metabolic rate of oxygen, cerebral blood flow, and the intracranial pressure. Dose-related depression of EEG. Isoelectric EEG occurs at 55% reduction of central metabolic rate of oxygen maintained at infusion of 4 milligram per kilogram per hour. For this reason, it is ideal for neuroprotection. Cases where, you have patients with traumatic brain injury, or even, when patients have just been resuscitated from, a cardiac arrest. So thiopentone is one of the drugs which can be used in the form of an infusion for neuroprotection. For the cardiac effects, predominant effect is venodilatation. It causes depression of cardiac contractility, causes increases in heart rate. SVR usually doesn't drop very significantly or increase significantly, decreases sympathetic output, does not sensitize the heart to catecholamines, which is done by halothane. Pharmacodynamics, respiratory effects, dose-dependent central respiratory depression, Respiration resumes minutes after the induction. Bronchospasm or laryngospasm at induction is rare. Okay, the reflexes remain intact even with the higher doses. Kidney effects, the flow and the GFR in proportion to the fallen blood pressure, which is not so significant with thiopentone. Hepatic effects, hepatic blood flow is reduced. For a long-term exposure, induction of hepatic enzymes and increased rate of metabolism can occur. Binding of barbiturates to cytochrome P450 enzyme system interferes with the biotransformation of other drugs, for example, tricyclic antidepressants. Promotes aminolevulinic acid synthase formation of porphyrins. Okay, so acute intermittent porphyria or variegate porphyria in susceptible individuals. So obviously, if a patient is known case of porphyria, this drug is contraindicated. Immunological effects, anaphylactic or anaphylactoid allergic reactions are not so common. Thiobarbiturates evoke mast cell histamine release in vitro, while oxybarbiturates do not. So where is it used? It is used, of course, most commonly in induction of anesthesia. Like we just discussed, in cases of increased ICP, so patients who have large tumors, patients who have traumatic brain injury causing raised ICP, then cerebral protection improves survival following focal brain ischemia. Cerebral protection again after a cardiac arrest, after resuscitation of a cardiac arrest patient, and refractory seizure disorders. Side effects, arterial injection can cause arterial spasm, thrombosis and necrosis. Okay, accidentally, of course, if you inject it. Treatment is you dilute the agent, okay, relieve the spasm, prevent thrombosis. So you can give papaverine or lidocaine, IV lidocaine, sympathetic blockade, and heparinization. Causes mild involuntary muscular movement, but not as much as etomidate. Inadequate induction dose may cause coughing and hiccups. Does cause placenta, also secreted into milk. Overdose can cause severe cardiorespiratory depression. Laryngospasm only if the plane of anesthesia is inadequate, if you have given too less a dose. And thrombophlebitis more common with 5% of thiopentone. Okay. So better to give it in a running line where you're flushing the line intermittently. And of course, avoid, make sure your arterial lines are well labeled so you don't accidentally inject into the arterial. Contraindicated in any patients with known or any familial history of porphyria. Induces enzyme aminolevulinic acid synthase. Increased porphyrin can precipitate an acute intermittent porphyria. Any patients who have hemodynamic instability, impending coma, adrenocortical failure, myxedema, and severe anemia. Thank you very much.